This conference will
Okay,
now
cool.
be recorded.
I have been in EMS for the last 5 years. I worked with MedX and Elko for a little while. I've been here for almost 2 years. I got my paramedic in 2023, so haven't been a medic for super long, but I really enjoyed it for the time I have been. So yeah, today we're going to talk about two different chapters. Chapter 11, we'll take a little break. Chapter 12, take a little break. We'll do a Kahoot if we have some time. And we're going to go home. Sound good to everyone? Okay, cool. Uh-oh.
Let me try clicking on it. Try it now.
Aha. Okay, cool. So chapter 11 is about our scene size up. So what does scene size up mean to you guys? Anybody have clues on? Like what are some things that would be included in a scene size up?
Scene safety.
Hazard, scene safety.
How many patients?
How many patients? Perfect, yeah. And why is that? Why is scene size up important?
Resources needed.
What was that?
Resources needed.
Yeah, perfect. Okay, cool. Okay, so today the learning objectives, we're going to identify hazards at the scene, determine if the scene is safe to enter. We're going to talk about mechanism of injury and how it can relate to our patient's condition. And we're going to determine what additional assistance may be needed on our scenes. So if you look at, I don't know if you guys have the skill sheets or not, but if you look at the skill sheets, it's the top section up there. And I actually include that first line, the PPE precautions, in my scene size up as well. So all of that top first section is what we're going to cover. So I think the scene size up is super important because it takes into account our own safety along with our patients. So one of the things that I've always been taught throughout EMT school and medic school is that your safety is number one, and then it's your partner's safety, and then it's your patient's safety. So a lot of times it's easy for us to kind of rush into a scene and want to be the hero of the day, thinking about our patient first, but it's pretty important to think about our own safety before theirs, because if we're not safe, if we get into some sort of trouble, we can't help them, right? Okay. So that first line talked about PPE and BSI. So what is PPE? Does anybody know what that stands for? What about BSI? Yeah, body substance isolation. Cool. What are some examples of PPE? Okay, cool, yeah. What about like bulletproof vests or those jackets, the extrication jackets that they wear, things like that can also be considered PPE, protecting yourself if you're extricating someone from a vehicle or, something like that. And so we already kind of discussed this, but why do we think about our PPE first? Protecting ourselves first, right? Like we always want to think about our own safety before anyone else's. So you could receive some information from dispatch before you arrive on scene that could alert you to the type of PPE you might need, right? So let's say you get dispatched to a woman in active labor. Like what are some types of PPE that we might consider using on a call like that? Gowns, maybe face masks, right, all of it, exactly, yeah. And then this also, again, protects us from infectious diseases, right? So how do those diseases spread from our patients to ourselves? Right, perfect, cool. So just another little note, dispatch could also give you information about the safety of a scene itself or what you might be walking into, but that information is not always correct. So that's why it's important to go through this scene size up every time you go on scene, because you might get information and it be wrong, right? Okay, so is our scene safe? So has anyone heard of the windshield survey before? No? Okay. So a windshield survey is when you're driving up to a scene, just like it sounds, you're going to survey out of your windshield before you take step out of your ambulance. You want to look through the windshield and kind of see what you can observe before you get out. So what are some things when you're pulling up to a scene you're driving up, you're looking through your windshield, what could you see that might be a potential hazard that you would want to be cautious of?
Fire.
Smoke, fire,
Gases.
power lines.
Stuff that's spilled everywhere.
Right, yes, spilled liquids. What about other people, pedestrians, frantic bystanders on scene, things like that, right? So we don't want to look just for what we can see though. We want to also listen and see what we can hear. So what are some things we might hear when we pull up to a scene? Screaming, other emergency vehicles like SOs or fire. And then we also want to look for things we can smell. So we talked about smoke, but we could also maybe have smell some chemicals or, especially if you're on an NBC with those big semis, you never really know what they're carrying until you see that placard. So if you smell a chemical smell or anything that just smells off, we want to be cautious of that as well. So this type of survey is continuous throughout the call. So it doesn't just happen once, right? So throughout the call, as we're doing our windshield survey, once we get out of our ambulance, and then throughout patient care, we want to continue this because things can change really quickly, right? So some other components of the scene safety step are establishing a danger zone, and then watching out for crime scenes and acts of violence. So if those are some sort of circumstances you're walking into, you kind of need to take precautions there as well, right? So we will talk about danger zones next. So once you do your windshield survey, you determine that the scene is safe to enter. We need to kind of determine a danger zone. So can anybody tell me what do you think a danger zone means? Like, what is that? Okay, and what does that mean? Don't go in, right, okay, cool. So when there are no apparent hazards, you looked out your windshield, you kind of assessed the scene, you don't think there's any apparent hazards. What do you think the minimum distance of your danger zone should be? 50 feet, perfect, okay. And then what about if you see a tanker truck that's spilled fuel on the ground or a fire, things like that? What's the danger zone for those situations? 100, okay, cool. And then what about hazmat or down power lines? Any ideas there? Okay, so it's variable, right? It kind of just varies. There's not a specific answer for that question. So especially with hazmat scenes, for different chemicals and substances, there are different danger zone distances, right? Where do we find information about hazmat materials?
ERG.
The ERG. Yeah. Okay. Yeah, so if you pull up on scene and you see a big semi truck with a placard, we need to look that up and figure out what our danger zone should be. And then what about for down power lines? How far, does anybody know like the standard for those?
Is it the round of the line from you or?
So it's actually,
Post
yes, it's posts. So if this is your down power line, let's say there's another power line over on this side, right? We want to be behind the first set of intact wires, right? So that just kind of keeps us away from that potential hazard. Okay, back to hazmat for 1 second. Where should we stage if there's a hazmat like leak or fumes?
level?
Upwind and uphill, right? So what happens if we're downhill or downwind? It comes towards us, right? Like if it's a fuel spill on the earth, let's not say fuel, let's say a hazmat spill on the ground, and we're downhill, that's gonna come towards us, right? Same if we're downhill of the smoke, downwind of that, it's gonna come towards us, and we don't wanna be in that line. Okay. So next we'll talk about crime scenes and active violence. So do you think you should enter a violent or dangerous situation to provide patient care? No. Okay. And then what are some signs that can indicate a violent or dangerous scene? Shooting, gunshots, okay.
Like screaming match.
screaming, yelling,
Unusual silence.
unusual silence, yeah, perfect. What about alcohol and drug use? That could be a potential, right? Some people don't like, aren't friends with alcohol or drugs, so you get a little crazy. Yeah, unusual silence is another one. Sometimes people don't think about that, but kind of if you show up on scene, I think it talks in your book, like the hairs on your neck start to stand up, or you just get that strange feeling, you know, maybe be a little cautious with that as well. And then also a knowledge of prior violence. So sometimes we get those regulars that we kind of know what their MO is, we know, you know, what usually goes on in those households. So we can kind of be cautious of those kind of people as well. Another one that we might not think of is animals. This is actually my boyfriend's dog. He's like, I need you to add this picture in because he looks like really scary there. So, you know, we never know about animals. Like they could look really scary and vicious like this, might not be, but it's always important to just kind of take that precaution and be careful there. And then we talked about yelling and shouting and things like that. Okay, so step 3 would be determining the nature of the call. So again, dispatch might give you some information, but you'll typically find out more once you're on scene. That dispatch info that they give you might not be correct. You know, there's been a lot of times that I've been dispatched to a call for one thing in particular and show up, and it's something completely different, right? So it's always up to you to kind of evaluate and figure out what's really going on. So we want to figure out why we were called. Is it trauma or medical? And then if it is trauma, we want to figure out their mechanism of injury. So what caused that injury, right? Whether it be a motor vehicle accident or, you know, a penetrating trauma or a blunt trauma, whatever that might be, we need to figure out that mechanism. And then if it's a medical call, we want to figure out their nature of illness. So what is medically wrong with the patient, right? A lot of times they can tell you that. Sometimes they can't if they're unconscious or, you know, for whatever reason, they might not be able to tell you. So index of suspicion. So when you show up on scene, if you see a car crash, you can have an index of suspicion that their mechanism of injury came from that car crash, right? So the index of suspicion is just kind of your idea of what might be happening, right? Your interpretation of what might be going on there. Okay. So in traumas, we're looking for their mechanism of injury. We want to know what caused the injury. There can be numerous things that could happen, but these are just a few. Motor vehicle collisions, falls, penetrating traumas, blunt force traumas are what was covered in your book. So first, let's talk about MVCs. So many injuries can come from MVCs. There's airbag deployment injuries. So these could cause abrasions or fractures. Airbags can deploy at speeds of up to 200 miles an hour. That's not in your book, but just kind of interesting. I mean, that's a big, big blow, right? So what are some injuries that we might see from an airbag? If an airbag deploys, what are some things we might see in a patient? Face and chest, gotcha. Sometimes there's like burn injuries because when it comes out so fast like that, it gets kind of hot, right? So burn injuries, abrasions, scrapes, lacerations, all those sorts of things. So what if an airbag doesn't deploy? Yes, that's a good point too, yeah. We would still want to be cautious because that airbag could still deploy. I think a lot of times, I might be wrong, but they will go in and actually like cut the battery before you go in to a vehicle where the airbag hasn't deployed. That's more of a fire expertise question that I'm not versed in, but yeah. So one thing that we might want to look for in vehicles where there's been an MVC where the airbag did not deploy would be a bent steering wheel, a bent or collapsed steering wheel, right? What are the potential injuries that could be present if we see this sign? Like if we see a bent steering wheel, what do we think the injuries might be there? Chest trauma, face trauma, difficulty breathing, fractures. Yeah. So what about a shattered windshield? Let me get my things up here. What about if we come on scene and see something like this? What do you think?
Or burn a seatbelt.
Hit the
Head trauma.
hit the
Head trauma? Yeah, perfect. Yep. Cool. Yeah, that spidering on the windshield, spider webbing, is a really good indication that the patient went up and over that steering wheel and hit their head on the windshield. So yeah, like we mentioned up here, we want to make sure our patient was wearing a seatbelt or not. We want to try to figure that out. What if they are wearing a seatbelt? What might be present if they were?
Bruising.
Bruising across the chest or across the abdomen, right? Cool. Then we also want to just take note if the patient was ejected from the vehicle. That's where a lot of really, really serious injuries come from, is with that ejection. So they, go up and over and through the windshield, which ends up being really serious. So 3 collisions that happen in a motor vehicle crash / collision. So the first collision that occurs is the vehicle hitting an object, right? So say we're driving along, we're sort of off the road, our vehicle hits a tree, okay? That's collision number 1. Collision number 2 is our body striking the interior of the vehicle, whether the airbag goes off or not. That would be collision number 2. So our car is going, we hit a tree, there's number 1. Because of the law of inertia, what does the law of inertia say?
Motion stays in motion.
Exactly, yeah. So just because our car stopped because of that tree doesn't mean our body's gonna stop immediately, right? Until we hit something else. So we hit the tree, our body continues forward, we hit the interior of the vehicle. That's number 2. And then number 3 collision would be our organs striking the interior of our body, right? So we hit the tree, our body goes forward, our body hits the inside of the vehicle, but those organs are still moving. So they continue going forward and hit the inside of our body as well. So those are the 3 collisions that happen in MVC. So why is that important to remember? Yeah, because we may or may not see injuries externally on the patient, but it's important to remember that there are 3 collisions, and that third one is especially important because there might be internal things going on that we can't see, right? And that goes back to kind of to the index of suspicion, like in these kind of accidents, we can have an index of suspicion that there may be internal injuries due to that mechanism. So let's talk about types of MVCs. So there's head-on collisions, kind of like we just talked about, you hit the tree head-on, right? So this is the highest potential for up and over or down and under injuries. So what do we think up and over means? Okay, yeah. What are some injuries that you might observe in a patient that goes up and over? Head, neck, chest, maybe, if they go up and hit the steering wheel, yeah. And then,
you also have your thighs as well?
so that'll actually be, well, maybe, I guess it kind of depends, but typically that's more of a down and under injury, right? So when they go down and under, what happens there? They're going down and under the steering wheel, and so what kind of injuries? You might see, yeah, legs, pelvis, maybe, hip, yeah. A lot of times that leads to the femur fractures as well, which are some pretty big, serious injuries there. So then we also have rear end injury, rear end MVCs. So when that happens, what kind of happens with the body in the rear end collision? Your head and neck kind of go forward, right? That whiplash type motion. So we can expect head, neck injuries in those situations. And then what about side impact? What do you think the body mechanics are in that kind of circumstance? Yeah. So typically in a side impact collision, it's like a T-bone, right? So you get hit by this on the side. Your body tends to move laterally while your head stays still. So that's kind of why that also leads to those head and neck injuries also, right? Kind of the same, the whiplash type thing, but I think it mentions that in your book, that your body moves laterally and your head stays still, so that leads to those neck injuries. And then rollover injuries. So any thoughts on rollover injuries? Yeah, there's multiple collisions, right? And rollovers are the most serious types of MVCs. And that's due to the potential for multiple impacts, right? So like you're rolling around down a hill and it's like, someone rolling down in a can or something, like you're just going all over the place inside that vehicle, right? So there's lots of potential for injury there. And then also possible ejections are another one to look for with rollovers. So, and then there's rotational impact. So, maybe your car gets hit on the rear end and you kind of spin out, right? Okay. Next is falls. So, falls can be serious. It's not always, Meemaw falling in her bathtub, which that can be serious too, but falls can be serious, so we need to consider the height of the fall. So what is the height for adults where we think is really serious? 20 feet, right? Cool. Yeah, if an adult falls from 20 feet or higher, that meets trauma center criteria. So we want to try to get them to the closest trauma center as fast as we can. And then for children less than 15 years old, that distance changes to greater than 10 feet or 2 to 3 times the child's height. So let's say they're 4 feet tall. If they fall from 12 feet, that's going to be, that's also going to meet trauma criteria. And then, that law of inertia also can apply here. So what happens if somebody lands directly on their feet? That energy is going to come up through the feet into the ankles and legs and hips potentially, so, and then, let's see. Another thing that it mentions is the surface the patient fell onto is also relevant. If they fell on a bed, maybe not so bad. If they fall 20 feet on the concrete, probably a pretty bad day, right? So what do we think about this patient here? There's a mom that calls, she's super concerned, her child fell. We show up on scene and we see this scene. What do we think? Serious or not serious? Not serious, right? Okay, cool. Okay. Penetrating trauma. I love this topic. Okay. So penetrating trauma is injury that's caused by an object that passes through the skin or other body tissue. So these can be low, medium, or high velocity. So what kind of weapon would cause, I guess not, what kind of object would cause a low velocity trauma?
Something pretty much thrown.
Yeah, nice, cool. And what about medium velocity?
Small weapons.
Yeah, handgun. And then high velocity would be more like high powered guns and rifles, things like that, right? So when we talk about guns and bullets, bullets can cause damage in 2 different ways. Does anybody know what those are? Cavitation or... Okay. So number 1, bullets can cause damage directly. So bullet damage is anything that's in its path, right? So you get shot, it goes directly through the body. There's a path that bullet follows, and anything in that path is going to be damaged, right? But not only that, number 2, bullets can cause pressure-related damage, which is also known as cavitation. So that's kind of what this picture is depicting here. So this gray line is that direct path, right? These little, I don't know, the bubbling out is that cavitation area. So it's a lot of pressure. It's causing everything inside to kind of balloon out from that direct path. And then blunt force trauma. So this is injury that's caused by a blow that strikes the body, but does not penetrate skin or other body tissues. So again, this is kind of like those internal injuries in MVCs, that third collision. Like signs are not always visible to us, right? And so that's why it says signs are often subtle and overlooked, because there might be internal things going on or bruising that's forming but not yet visible to us, that could be overlooked. So we need to kind of evaluate our patient based off the mechanism of injury. So let's say that somebody gets hit in the head with a baseball bat full force. Like, what are some injuries that our index of suspicion would be, pointing towards there?
Dark bruising.
Bruising, brain bleed, maybe fractures, skull fractures. What about, eye issues, things like that, right? Okay. Does anybody have questions about the trauma section, mechanism of injury?
So one thing that we need to, I don't know if anybody's seen it in their book. Has anybody seen the words coup contra coup? Does anybody know what it is? Anybody?
Was it the hitting and then the hitting again?
Yeah.
You write it down.
So contra coup, Jesus Christ. I need to be closer to Hannah so they can hear me down there.
There's another mic.
Yeah. So coup contra coup, right, is basically what your brain does inside of your head when you have a sudden impact and stop, right? So you think about it like a car accident, right? Your head comes forward, you hit a windshield, your brain goes forward, right? When you hit that windshield, your brain's going to go forward, slap the front of your skull. You're going to go back, it's going to slap the back of your skull and then the front of your skull, right? Coup contra coup, right? So be considerate of that. There,
Spelled like contra coup.
Yeah.
But it's just pronounced like.
yeah. So be mindful of that in car accidents or stuff. Secondary injuries, right? Like spinal, abdominal, chest, all of that stuff with that blunt force trauma from a car accident. But the coup contra coup is another big one that you might see on National Registry. And it may or may not be in the test that you see here. So be mindful of that. Another big thing to be mindful of whenever you're talking about these blunt injuries to the head, face, especially, is the possibility of bleeding into your mouth, right? So you think when you get hit in the face, if I get hit in the top lip right here and bust all my teeth out, right? Does all that cause like airway obstructions, stuff like that? So if you walk up to a patient that just got slapped in the face with a baseball bat, that needs to be a high index of suspicion, right? If they sound like they're not breathing adequately. And there's two separate ways that we check these things, right? Does everybody know what ABCs are? Right? There's one big difference in that is with unresponsive patients, trauma patients, medical patients, or patients that have severe bleeding. It is CAB, right? So you heard about that, right? Where you stop traumatic bleeds first, or if you have unresponsive patients, you go and check circulation first, right? So just be mindful of those two things. That's another week. Sorry.
Okay, any questions there? Any of that? No? Okay, cool. So next is the medical side of things. We want to figure out our nature of illness. So what is medically wrong with the patient, right? Okay, so we can gather clues about what might be wrong from our surroundings. So let's say we walk into a patient's house. What might we observe that could give us clues into their nature of illness?
Medication.
Medications. What about like the cleanliness of their house? Could that be a sign? Possibly, yeah. And then also their patient's presentation. That'll be something we talk about, I think, in the next chapter, our general impression of the patient. But also looking at that can kind of give us clues on what our nature of illness could be. We can also kind of obtain some information from the patient if they're alert, obviously. We can ask, hey, what's going on today? But if they're not alert, hopefully there's family or bystanders nearby. We can ask them for some information. And sometimes we can't, right? Sometimes we don't have the patient to ask because they're unconscious. Sometimes there's no family or bystanders there on scene. So it ends up being our job to kind of be a detective and investigate, figure out what's wrong with the patient, what their nature of illness is. Step 4 is our number of patients. So, you know, we show up on scene, do an MVC, we need to figure out how many patients do we have. Was it just one driver that hit a tree, or did we have a multi-vehicle collision where there's, you know, 6 people in one vehicle and 2 in the other? Figuring out that number of patients can kind of help us determine what additional resources we're gonna need. Yeah, so let's say we had 10 patients on scene, we're gonna need more help, right? We can't take care of everyone with just our 2 providers. So that comes to number 5, is to request additional help if needed. We can request other ambulances come and help us out. We can request law enforcement, fire, any of those additional resources we might need. And then on the skill sheet, it has number 6 is to consider your ceasefire precautions. So just going off your mechanism of injury, sometimes you can tell that you might need to, you know, consider ceasefire there. But one thing I wanted to note is that just because these things are in a certain order on your sheet doesn't mean that that's the order you're necessarily going to go in on a call, right? Like you might show up on scene as you're doing your scene size up, your windshield survey, and see that there's hazmat to deal with. And so you might need to call for additional resources at that point, right? So all these steps are kind of variable and interchangeable. You just kind of have to assess and be a detective as you go to figure out, you know, what order you need to do things in, right? So I think that's all for this chapter. Are there any questions on that? No? Okay, cool. Do we want 5 minutes to go to the bathroom or get water, or you're all good? Yes? No? Everybody good? Okay. All right, it'll take me just a second to get the next slides up, so just give me a moment.
Yeah, we got it on Wednesday. Unless you get Tuesday on or Wednesday on. Maybe Wednesday on.
What time you start? You gotta be there, I guess, 6:30. Just, the door closes like 12. I need to write this shit down or something.
Oh, you see,
Did anybody online have any questions?
So I think when we go back this week, they're gonna be people that have.
Either send me a question or send me an all good so that I know you guys can still hear me.
Well, I don't know what all the college people you got. Levi would. Yeah, I did the manager. They spent $2 million on all these shirts. The last one. Well, I already wear my glasses every.
Okay, you guys ready? Okay. All right, so chapter 12 is on the primary assessment. So, there we go. Okay. So that will be the second section down on your skill sheets there. I'm sure you've all looked at these sheets before, right? Yeah. Okay. Okay. So number 1 in our primary assessment is going to be our general impression. I've heard this referred to as our doorway assessment. So this is what we see as soon as we walk in the door. Right when we finish that scene size up, right, we're going to look around the scene, see what we can investigate and discover there. And then we're going to look at our patient. and see what our patient looks like, and we're gonna kind of get a general impression just by looking at them, right? So I'm sure there are some times where you've seen a sick person and you can tell they're sick. You look at them, they're maybe pale, they're clammy, they just look sick. So we can kind of get a gut feeling of, is this patient sick or is this patient not sick, just by looking at them. So what are some things in a patient that we might look for during our doorway assessment? Right when we walk in, what might we observe of our patient? Skin color. Okay, anything else?
Blind side,
Breathing, talking, yeah, that's a big one.
tripoding.
Tripoding, perfect, yeah. So we want to look for, we want to assess, how does my patient look? So are they alert or are they unconscious? Again, are they sick or not sick? We can tell that a lot of times just by looking at someone, right? Skin color and condition, and then positioning. I think we hit all of those, so that's perfect. And then we want to look around our scene for some clues. We talked about that last chapter, but you know, maybe we see an overturned ladder, and they're laying on the ground. You know, might clue us in that they fell off the ladder. Drug or alcohol containers around can kind of give you an indication of what might be going on with our patient. And then are they outside on the concrete in the cold, right? Like maybe they're hypothermic. So just those scene clues again can give you a general impression of what may be going on.
So on darker skinned people, it's us to see their lips and their nail beds and stuff.
Mhm.
Is it pretty easy to see that, or most of the time?
I mean, if you pull down their
Eyelids?
lower eyelid, you know, if it's really bright and pink in there, then that's normal.
Right.
If not, it's gonna look pale. And on Thursday, when we go over chapter 13, I actually have pictures of that to show you guys too, so. So let's say, I know he's in a hospital here, but let's say we walk in a house and we see our patient positioned in this way. What are some things that, first of all, what is this position called? Tripoding, and what does that tell us? Perfect, yeah. Are there any other, no, it's very skinny, right? What about skin color? Maybe a little pale-ish. It looks like he's on oxygen, so that can also clue us into, you know, maybe this is a respiratory thing going on, right? So yeah, you guys were correct. Tripod position. So this next one, does anybody know what this body signal is called?
The blind side.
If he's doing it like that, it looks like heart pain. If he does it like, then that means he's choking.
Okay, yeah.
The blind side.
Okay,
That's what the book has.
yeah, so this is Levine's signal. Typically, if they're choking, they'll have it more like up here, right? But yeah, Levine's sign, hand over the chest, really like clenching that chest there. And that tells us there's probably some sort of chest pain going on, right?
I remember that because when people see Adam Levine, they're like,
Okay, so next on our list, we want to look at mental status and responsiveness. So how can we determine a patient's level of consciousness? Are they responsive, but how do we know? Ask them, talk to them, right? A&O, gotcha, yeah. So the first little acronym that we can use is AVPU. Does anybody know what this stands for? Okay, cool. So if they're alert, obviously up, talking to you, hey, I feel like crap today, you know, they're able to kind of interact with you, right? Verbal, actually had a patient today that was probably more like the V here, verbal. They kind of only respond when you talk to them. They only open their eyes, or, you know, get aroused when you speak to them. Pressure, pain, how can we, what are some things that we can do to invoke pressure and pain ethically on a patient? Sternum rub, right? We can maybe squeeze a finger or a toe. Sometimes that can work. And then they could be unconscious, right? So, yeah. Okay, and then their A&O level. So person, place, time and date and event. So how would you ask a patient A&O questions? How would you word them to your patient? Just one person. Somebody raise your hand. Give me an example.
There's a cup of doom over there.
Starting an introduction, you ask them, hey, and this, talk about you, they tell you who they're their name, so you check that out. You know where you're at right now? Cool. You know what time this started happening? All right, great. And what was the cause of this?
Yeah, perfect. That hits all of your points there. So, what is your last name? Do you know where you are right now? What's the month that we're in? Sometimes the day is hard, because I don't even know the day sometimes, right? And then the event. Why are we here today? What's going on? Just like you said, that's perfect.
Hey,
Hey,
whenever, sorry, I'm just, whenever, somebody asks a question, try to repeat it back.
okay.
Just for the folks in Austin, just because they can't really hear everybody really well, so.
Okay.
So they don't think you're just rambling about.
Gotcha. I haven't checked on their chat either, so I don't know if they're
Yeah, no,
talking to
they're-
me or not, but, okay. Cool. Okay, so once we figure out their mental status, we get a general impression, we figure out their mental status, we're gonna try to figure out that chief complaint, nature of illness, mechanism of injury, try to figure out what's going on, and look for life threats, during this time, right? So we kind of already talked about this, but how can we determine the patient's chief complaint? Ask them, right? Perfect. If they're alert, we can ask them. What about if they're unconscious?
Start using your ABCs.
So what is their chief complaint if they're unconscious? They're unconscious, right? That's their chief complaint. If they're unconscious, their problem is that they're unconscious, right? So we want to figure out what's wrong there. But if they're alert and you ask them, they might be specific. They might say, my chest has been hurting for the last 5 days and I just don't know what's going on. It's radiating down my left arm and I haven't been able to breathe, et cetera, et cetera. Or they might be really vague. I just don't feel good. It's like, okay, well, why? Got to dig a little deeper there. So, as we're going on with this portion of the assessment, we want to see if we can observe any life threats. So do we see spurting blood coming from their leg? That would be a life threat, right? Like immediately as we see those things, we want to address them and fix them. So like we said, they might not be able to communicate that chief complaint to us, so we have to be a detective. Talks about in your book, you can look at the patient's age, sex, and positioning. We can listen if we hear groaning, snoring, or gurgling respirations. What might snoring respirations tell us?
Lower airway.
What?
Lower airway.
An upper airway obstruction.
Perfect. Yeah. Yeah.
Lower something.
If they have snoring respirations, we're going to want to open that airway for them if they're unconscious, right? How do we open an airway? Perfect. Okay. What about gurgling? If we hear gurgling respirations? Obstruction. Okay.
Liquid, it could be like a mucus or blood or something like that.
Yeah. A lot of times there's the vomit, maybe over salivation. They've got a lot of saliva going on and they're kind of gurgling on that. That could be a thing, right? And again, we want to smell for different things, maybe hazardous fumes. That could be a reason that they're not feeling good, right? Urine, feces, vomitus, or decay, all of those things can kind of say, okay, something's going on here, right? And then it goes into spinal motion restriction. So you should begin spinal motion restriction on any patient you suspect may have an injury to the spine based on mechanism of injury, history, or signs and symptoms. So if we are going to start spinal motion restriction, we'll start with manual stabilization. So holding that head still in a neutral inline position. What are some situations where we might consider spinal motion restriction? Okay, what?
Emergency moves.
Okay,
A fall?
a fall, right? Yeah, any trauma like where there's a potential for a neck injury, we want to consider that C-spine, those C-spine precautions, excuse me. So what if you're alone? What if you don't have the capability to hold C-spine and do all the other things you need to do? What then?
C-collar.
C-collar, if you can get that, right? Exactly, yeah. So if you're alone or you have limited resources, spinal motion restriction is not the priority when there are life threats to manage. So if it's just you on scene and your patient's not breathing, but they fell off a ladder, which one should we prioritize? Breathing, right? Like if they're not breathing, then their neck is really not a concern to us, right? And this is kind of what that manual stabilization looks like. Holding both sides of the head, supporting that inline position there. Okay, I think Becca said this little saying before, but air goes in and out, blood goes round and round. Any deviation is a life threat, right? So we have our ABCs, airway, breathing, circulation. So when we're assessing the airway, we want to ask, is our airway open and patent? So what does patent mean?
Clear.
Clear, open, right. And how can we assess that? How can we tell if the airway is patent?
How it sounds, how their chest is rising.
Chest rise and fall, yeah. Yeah, talking to them if they're alert. Cool. Breathing, is our patient breathing adequately? So what is adequate breathing? 12 to 20 a minute. Yeah, not a lot of crazy lung sounds going on, like wheezing might not necessarily be adequate, right? And then circulation. So does our patient have a pulse? That's number one, that's important, right? Is our patient perfusing well? What is hypoperfusion? Shock, good. How can we tell if our patient's perfusing well? Good skin color, right? If they have a strong pulse, right, that would be probably good perfusion. We can check that cap refill, right? I don't know if we talked about that yet or not, but then what is exsanguinating bleeding? Right, leaking it all out, exactly, hemorrhage. So we want to, in that C step, we want to look for hemorrhage, any bleeding that's going to be a life threat, major bleeding, let's say. Maybe not a laceration, but a spurting laceration might be a life threat, right? So Chaz touched on this just a minute ago, but ABCs or CABs, so how do we figure out the order in which we're going to assess these things? Okay, cool, yeah.
Life threats.
Life threats, what we can see, what we observe, right? So a patient without a pulse is dead, right? So is breathing for a dead person going to help them necessarily? It will, but not if the blood is circulating, or not circulating, right? So if they don't have a pulse, their blood is not moving around their body, correct? Yes, okay. So if we're ventilating for them, giving them oxygen, the oxygen's not circulating in their body. So it's really not doing much good for them. So if you come up on a person that does not have a pulse, what is most important, A, B, or C? C, circulation, perfect. Yeah, again, if someone's dead, the most important intervention is to circulate the blood. So without blood circulation, the ventilation you perform and the oxygen you administer will not flow around the body. So CAB for patients with no pulse or breathing. But there is an exception. So if the arrest was caused by respiratory failure, then you want to start with A first. So let's say you have a patient that is a drowning victim. You pull them out of the water. What's the reason that they're unconscious without a pulse? It's because they didn't have air, right? They weren't able to breathe. So therefore they didn't get enough oxygen. So therefore their heart stopped. So when you pull them out, we want to address the thing that caused the problem first, right? Which would be their airway and their breathing. So again, the order depends on the order depends on the patient's specific condition. Are there any questions about this? No? Okay. So we're going to do a couple little scenarios on airway, if it's patent or not patent, okay? So number one, your patient's able to speak to you in full and complete sentences. Is the airway patent or not patent? Patent. Cool. Okay. The patient is unconscious and you hear gurgling airway sounds. Not patent. Cool. And then the patient is alert, but grasping at his throat and turning blue. The patient's unable to speak. Okay, cool. Pretty self-explanatory, I think, right? Yeah. Okay, so how can we fix a non-patent airway? Give me some examples of things we can do for a non-patent airway. Let's say they're gurgling. What do we do for that? Suction. Cool. So if their airway is not patent, we're going to try to manually open that airway, right? the 3 different ways we can do that manually would be a jaw thrust maneuver for traumas, right? If we suspect neck or head injury, we want to use that jaw thrust maneuver. Have you guys gone over how to do that yet, or no? You have? Okay, cool. The head tilt chin lift maneuver for medical or non-traumatic patients. And then in children, we want to put them in a sniffing position. Have we talked about that yet? Yeah. Okay, cool. So there's your head tilt chin lift, your jaw thrust, and then that sniffing position for the little ones. Okay. We can also use an adjunct. We have OPAs or NPAs, and that's what those look like. And then we can suction if needed. Have you guys gone over inserting OPAs and NPAs?
Yeah.
Okay. All right, now on to B, breathing. How do we assess for adequate breathing?
Equal bilateral chest rise and fall.
Okay, cool. What else? Listen. What about their rate? We can try to figure out their rate, right? Respiratory rate. So here's some of those things. We want to look for equal chest rise and fall. Flail chest and paradoxical motion is not adequate. Do we know what flail chest and paradoxical movement are? Separate, right? Okay. We want to look at their rate. What's the average rate for adults? 12 to 20. I can't tell you the pediatric ranges, so I don't have them memorized. Sorry. We want to look at their depth, their breathing depth. So are they taking full, nice deep breaths, or are they breathing kind of shallow and, you know, not getting that full, nice deep breath? Are they using accessory muscles? That could be an indication that we don't have adequate breathing. You know, they're really struggling to get that breath in and using those muscles to kind of help with that. We can listen to their breath sounds. So if we hear wheezing, stridor, you know, rhonchi, those things might indicate that we don't have adequate breathing. And then we can also look at their O2 saturation, but that's really like the last thing that we want to look at, right? Like we might have a good O2 saturation, but there might be problems reflected in that number, right? This was just a good little picture of flail chest. It's kind of interesting. So yeah, you have that section of the broken ribs there. When you breathe in, what is the pressure like inside your chest cavity? Negative, right. So if you have that section of broken ribs, you have negative pressure. And that's actually, when you inhale, your ribs typically expand, right? But that negative pressure is going to pull that flail segment in, negative pressure, sucking that section in, right? And then when you breathe out, there's positive pressure. So it's pushing that unattached section out. Not necessarily important for you guys. I just thought it was kind of cool to know, but. Okay. Is the patient breathing on their own and adequately? So if they are breathing on their own and we determine that they're breathing adequately, we can give them supplemental oxygen or we don't have to do anything, right? Like if they're breathing adequately and on their own, maybe we don't need to do anything for them for their breathing, right? But maybe their saturation's a little bit low. We just put them on a nasal cannula or a non-breather or something like that, right? So if they're breathing on their own but inadequately, oh, there's that non-breather. If they're breathing on their own but inadequately, we might want to give them positive pressure ventilation with 100% oxygen. So assisting that ventilation process there. And if they're not breathing on their own, we need to perform rescue breathing and positive pressure ventilation again. Okay. So circulation, we want to figure out if there's any deficits in their circulation. So we want to check their pulse. Is it present or absent? Is it slow or fast? Weak or bounding? What does weak and bounding mean? Anybody know? As far as it relates to pulse? Weak would be like, you can barely feel it, you know, it feels like ready, we'll talk about that more on Thursday too, but bounding would be a nice strong pulse that we can feel. It's nice and strong and regular, right? Again, we want to look for that exsanguination or hemorrhaging. If they're spurting blood out of their leg, we need to fix that pretty immediately. We want to look at their skin. Is it warm, pink, and dry, pale, cool, and diaphoretic, or an ashen color? What can pale, cool, and diaphoretic skin indicate? Shock. Yeah, perfect. And then we can assess their capillary refill. This is more towards pediatrics, but you can still do it on an adult too, right? Should the cap refill be less than or greater than 2 seconds? Less than 2 seconds. That means they're perfusing well throughout the body, all the way to the extremities. That's kind of like an example of that cool, pale, diaphoretic, kind of ashen color and skin condition there. So then we want to, after we look at our ABCs, we want to determine the patient's priority. So are they sick or not sick? If they're not sick, maybe we can hang out on scene, we can do a couple interventions. Don't have to be in such a rush, right? If they're sick, then we might want to maybe hurry that up a little bit. Are they stable or unstable? If they're stable, again, we can kind of hang out and play for a little while. But if they're unstable, we probably need to get rolling as quickly as we can to get them to definitive care, right? So high priority patients, some examples of those, they're unstable patients, right? So any threats to your ABCs, they're unstable, and we need to quickly get them moving. If they're unresponsive, they're unstable. If they're responsive but altered, they're also unstable. If they're in shock, if there's uncontrolled bleeding, or if they have chest pain consistent with cardiac problems, all of those situations will be considered an unstable patient and a high priority. So to be stable, a patient needs to have vital signs that are in the normal range or just slightly abnormal. Stable patients can become unstable though. So this is like we talked about in the scene size up. We're always reevaluating our patient because just because when we arrive on scene they look okay, that doesn't mean that their condition can't deteriorate while we're treating them, right? So continual reassessment is always required. Okay, that's it. Any questions? What questions do you have for me? Rephrase. Anything there? Cool. Okay. What time is it? 7:04. Okay, we have 30 minutes, right? Okay. Cool.
They're ready to go. I don't know if we're gonna let them go early or what, but yeah. I did want to show them a video real quick.
I'm fine. Let's get them.
Okay. I did keep them longer on Thursday, so I feel like it'd be nice, but I mean, it's up to you. They said we are following along. That's all I said.
Okay, got that.
Okay. So I did want to show you all this video. You guys need to go to the bathroom real quick. I just want you guys to watch it and tell me what this guy did wrong. Kind of green. not do?
Anything, and just.
Any,
For real.
what would have been the proper BSI or PPE for him?
Level A.
Probably have that. Needs mask, needs a CPA, right? Didn't take any of that into account. Yeah, so I think that's everything Hannah had for y'all. Unless y'all really want to do a good news, but I feel bad because I kept y'all late last Thursday, so if y'all want to go home early today. Is anyone opposed to that? I didn't think so. All right. Do you guys have any questions? All right, so make sure that whenever you guys get here on Thursday, you're ready for that other test. Make sure you're studying this chapter, alert, verbal, tangible, and responsive. Hannah did a really good job on hitting all the things that were gonna be on this next test. So keep that in mind. So, anything else?
It's all like common sense. Other than knowing.
Yeah.
This is the only chapter I really wasn't worried about. Well, I'm worried about the last one.
Pull up the go-to. All right, awesome, thank you.
Okay. How do we need to clean up in here? Can we?
That's gonna be a question for Mike. Let me pull this.